Morning, everyone. Thank you for joining us. My name is Ian Paterson. I'm a cardiologist and chair of today's third annual Rare Cardiac Conditions Conference. And on behalf of my co-chair, Dr. David Birne, we're very pleased to welcome you to the conference this year. And I'm very pleased to tell you that we have had tremendous interest this year. We have over 450 registrants. Which is a 60% increase from last year. So phenomenal interest in the conference this year. So we're very pleased about that and very thankful for everyone who's joining us today. To help us launch today's conference, very pleased to welcome Dr. Rob Beanlands, the President and CEO of the University of Ottawa Heart Institute. Dr. Beanlands is going to talk to us today about why he feels the Rare Cardiac Conditions program is important, both at the U of O, and also tell us why he thinks this is an important meeting as well. And with that, please introduce Rob.
Thank you, Dr. Paterson, and welcome everyone. It is certainly my honor to provide these opening remarks on the Rare Cardiac Conditions Conference, the third such conference of its kind. This informative event coincides with Rare Diseases Day, held the last day of February each year. And it's a day dedicated to raising awareness and driving action for the understanding and care of people with rare diseases. There is increasing awareness of this, and I think the fact that the conference has pretty much doubled its registration from last year to this year, and almost 500 registrants suggests that awareness is rising, which is great. And obviously this will be our focus today. Because these are uncommon conditions, they get less attention, they often get less grant funding, they're less well understood, they're harder to study and to treat, and treatments are not well investigated. However, we know that many heart diseases, common or uncommon or rare, are largely preventable, or if detected early, can be treated to delay progression, improve survival, and improve quality of life. It's these facts that prompted the establishment of the Canadian Centre for Rare Cardiac Diseases at the University of Ottawa Heart Institute. This is a concept emerged from discussions with Dr. Andrew Crean, who was at the Heart Institute several years ago, and David Birne. And I have to say, it's David Birne's commitment to this, with support of the Heart Institute by the then CEO, Dr. Masana, and the Division of Cardiology, that led to the development of the Rare Cardiac Disease Center at the Heart Institute. There's ongoing research in this field in Ottawa, but obviously elsewhere in cardiac sarcoidosis, amyloidosis, pericardial disease, microvascular disease, to name a few. And you're going to be hearing a lot about these, as well as genetic cardiomyopathies and so on today in this exciting meeting. And from these, we hope that they'll emerge frameworks for care and therapies in the future. And also, this is what motivates us to undertake this conference. And I'm so pleased that everybody is here today. And I'm grateful that everyone has volunteered your time to participate. I sincerely believe that what we learn here today can save lives and improve quality of life for people with rare and uncommon cardiac conditions. So we'll be welcoming you, nurses, physicians, scientists, allied health professionals, and our patient partners. Really looking forward to hearing their stories, putting a reality perspective on everything that we're trying to do, but we all have a role to play. I also want to acknowledge the dedicated team at the Heart Institute for their hard work in the Canadian Centre for Rare Cardiac Conditions program and field. A special thanks to Ian Paterson, who is our director, David Birne, who is co-chair of this meeting, and Haley Morton, who oversaw and overseeing the logistics of this meeting. Without her help and support, this certainly would not have been possible. So you're going to learn the latest and greatest updates, the best practices in rare cardiac conditions. You'll hear from national and international multidisciplinary leaders and patient partners. I want to thank everyone for sharing your experiences and knowledge, your stories, your time, and for enriching and informing our discussion here today to what matters most. I look forward to another inspiring event. Thank you very much. Ian, back to you.
Thank you very much, Rob. Much appreciated. Okay, so before we get started, I was just going to give everyone a brief overview of rare cardiac conditions and what to expect with today's conference. So here are my disclosures. And so some of you might wonder why we've chosen this day to have as the day of our conference. Well, Rare Disease Day falls at the last day of February each year. And in fact, last year, of course, was a leap year. So it fell on February 29th. So obviously, that's the most rare day in the calendar. So we've decided to try to coincide our conference with Rare Disease Day. And so there are many events happening around the world to commemorate rare diseases. But as far as we know, we're the only conference and really program dedicated to rare cardiac conditions. And so some of you may also ask, what is a rare disease? So it turns out Canada doesn't really have a definition, but basically a rare disease is something that affects less than 1 in 2,000 people in the population. But there are very many rare diseases that have been identified. There's been 7,000 of them. Most of them have a genetic basis. 80 to 90% of them have a genetic basis. And that's why a lot of the content for today's talks will also have a genetic component to them. Because there's so many rare diseases around, it's been estimated that most of us know someone affected with a rare disease in our personal circle. In Canada, it's been estimated that there are 3 million people, worldwide 500 million people. And as Dr. Beanlands just mentioned, there are problems with access to treatments. A lot of these conditions don't have approved therapies, and part of it is the funding issue. Thankfully, though, Canada has come up with an initiative to improve access to drugs for rare diseases. In 2023, they launched a $1.5 billion initiative towards this. What's happening here locally at the University of Ottawa Heart Institute? Well, we have founded the Canadian Centre for Rare Cardiac Conditions, which launched in January of last year. We have several fantastic existing programs dedicated to care of patients with rare cardiac conditions. We launched 2 new programs in 2024, one on coronary microvascular disease and one on pericardial disease. And we were inspired by our first speaker that we'll be hearing about this morning. And we plan to launch a genetic cardiomyopathy program later this year. What else did happen in 2024? We launched a fellowship program, a training program, and we welcomed our first fellow, Dr. Edgar De Silva, in July. So he's been working closely with us and joining all of the rare cardiac conditions program at the University of Ottawa Heart Institute. And he'll be one of our speakers this morning with our patient representatives, patient partners. And he'll also be involved with speaking at some of the workshops this afternoon as well. And so we would encourage, if there's any trainees out there who are thinking about a fellowship or further training in rare cardiac conditions, or know someone, feel free to contact us about this opportunity. Okay, so this is our agenda for this morning. So this morning we have our plenary session. So we have 6 topics, which we've divided into 2 sessions. So we have 3 topics in the morning and early morning, and 3 in the late morning. Each one is a 25-minute talk, and there will be 10 minutes for questions afterwards. So we ask for members of the audience to please type your questions in the chat, and we'll get to your questions at the end of the 25-minute talks. I just want to highlight, we've got a number of great speakers, local speakers, national speakers, international speakers. The first session, the theme is genetics, and the second session, the theme is optimizing accessibility and care. And I just want to highlight our 2 patient partners that'll be involved with one of our morning sessions this morning. So we're very pleased about that, very anxious to hear their talk. And then later on today, we have several subspecialty programs going on. They divide into 2 sessions. And many of you will be joining us this afternoon to listen to at least 2 of these sessions. They're 90-minute sessions. The format is meant to be very interactive, so you'll have opportunities to interact with the speakers and the moderators. So we're looking forward to that this afternoon. I want to highlight we have 2 new sessions this afternoon, one on genetic cardiomyopathy, which will be co-chaired by Dr. Sanela Music and Dr. Omed Kiamanesh. And we have another new session on coronary anomalies, co-chaired by Dr. Marcus Schwartzman and Dr. Andrew Crean. So a couple of housekeeping items. So this conference has been approved for 6.5 hours of Group 1 credits from the Royal College for CPD credits. So at the end of the conference, we'll be sending everyone an evaluation form. And once you fill that out, we're happy to provide you with the credits. The conference is recorded and will be available for viewing afterwards. In fact, you can see last year's conference and the prior year's conference available if you go to our website. And as I mentioned earlier, we'll have a Q&A session after each 25-minute talk this morning. I also want to very much thank our sponsors today. We have had great support from a number of industry sponsors. Pfizer is our platinum sponsor, and then Alnylam, AstraZeneca, Bristol Myers Squibb, and Sanofi are old gold level sponsors. So thank you very much. And with that, I want to wish everyone a great meeting, and I'm going to hand over to my co-chair, Dr. Birne, who's going to introduce our first speaker.
Thanks, Ian. I'm pleased to introduce our first speaker, Dr. Julia Cadrin-Tourigny from Montreal. She specializes in electrophysiology, cardiovascular genetics, practices at Montreal Heart. She did most of her training in Montreal, but then did a postdoctoral clinical and research fellowship in cardiogenetics at Johns Hopkins. Her main research interest is in the prediction of arrhythmia outcomes in cardiomyopathies. She's truly a rising star in the cardiovascular genetics community, and also a fantastic presenter. I've heard her a couple of times, so look forward to hearing your talk today, Julia.
Thank you very much, David. You're putting a little bit of pressure. I'm very. It's a true honor to be here today and speak about such an interesting topic. These are my disclosures, and so this is a pretty vast topic: genetic cardiomyopathy and arrhythmia. So what could we be talking about? So genetic cardiomyopathy. So we have hypertrophic cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy. And I would divide the left side of the heart in non-ischemic cardiomyopathy with arrhythmogenic genes and with mostly garden variety genes, normal genes that are not super arrhythmogenic. And what arrhythmia could we be talking about? So first and foremost, because I think this is the most difficult and interesting part, sudden cardiac death, which we want to predict mostly and prevent, ventricular tachycardia, atrial fibrillation, and in mainly one specific case, atrioventricular block. So first part and first topic of the presentation, prediction and prevention of sudden cardiac death. So why is it important to predict and prevent sudden cardiac death? Well, many of these genetic cardiomyopathy are at significant risk of ventricular arrhythmia and sudden cardiac death. Secondary prevention is pretty easy. So when you have someone with a ventricular arrhythmia or a sudden death, you don't let them have that a second time and not be protected. So you implant an ICD. In primary prevention, so trying to predict who will get a ventricular arrhythmia or sudden cardiac death is difficult, and it changes from disease to disease. And it's very important to do, predicting these ventricular arrhythmia events before they arrive, because how we prevent them is by implanting a defibrillator. But at the same time, while we want to prevent all these sudden cardiac death from happening, we want to avoid the complication of implanting defibrillators, mostly in the young population who can have long-term complications. But the problem is it's hard to make prediction, especially about the future. And there's so much truth in that truism that it's been said by many important and intelligent men before me. When we're talking about risk stratification in genetic cardiomyopathy, we can kind of organize our thought in two different ways of classifying these diseases, by phenotype or by genotype. So the phenotype that we have, what these diseases look like. So it's either mostly hypertrophic cardiomyopathy, that it has its own set of risk prediction, arrhythmogenic right ventricular cardiomyopathy, which we can recognize, and non-ischemic cardiomyopathy. But then in non-ischemic cardiomyopathy, we're getting more and more specific into different genes that can cause non-ischemic cardiomyopathy and have a higher risk of ventricular arrhythmia. And from this table, we're going to concentrate in 4 different disease or gene-related diseases: HCM, ARVC, desmoplakin, and Lamin cardiomyopathy. So first disease, hypertrophic cardiomyopathy, which, may not pretend to be a rare... Okay, I think I froze for a second. So may not pretend to be a rare disease, as it's present in 1 in 500 patients. Risk stratification, for the past 10 years, we've been using 2 different ways to predict ventricular arrhythmia in these patients. So either by a risk factor first based approach, which has been proposed by the Americans. So the risk factors are family history of sudden cardiac death, massive left ventricular hypertrophy, a septum of more, or any wall of more than 3 centimeters, unexplained syncope, and have been added later in the process and in the most recent guidelines in 2020 and 2024, apical aneurysm and LVEF less than 50%. On the other side, the European have based their risk stratification for the past 10 years on a risk calculator, which includes age, thickness of the wall, left atrial size, LVOT, family history of sudden cardiac death, non-sustained VT, and unexplained syncope. And they advise to put in a defibrillator if the risk is above 6% in 5 years. Why should we use risk calculators? What is the aim of complexifying risk stratification with a risk calculator? So the objective of doing that is trying to integrate the whole literature into one single number. So to use different predictors at the same time with different weights, which may have interactions, which may have additive value. So when we add multiple predictors, it might increase the risk, and to include continuous variables. So for example, LVOT or age as a continuous spectrum rather than putting a very strict threshold. And this gives us an absolute number, which we can use in a conversation with patients. So this sounds very interesting, but it has limitations. The prediction is not perfect, even in these risk scores. And all of the risk scores that have been proposed for genetic cardiomyopathy have C-statistic between 0.70 and 0.80. What that means practically is that 70 to 80% of the time, the risk calculator would give a higher risk to someone who will end up having an event versus someone without an event. So the rest of 20, 30% of the time, the calculator may be wrong. It may not include all the risk predictors. So for example, for HCM, apical aneurysm and LVEF were not included. And it's not good for a rare situation, which have not been included necessarily in groups large enough in the development of the model. And risk stratification, thus, is not perfect. So the sudden death occur even at low risk. So there has been a publication from another group externally validating this risk calculator showing that many events occurred in the very low risk group. However, as a limitation, so many of these patients who were deemed at low risk when only considering this true number from the risk calculator had very high risk based on single risk factors. So for example, a septum more than 3 centimeters or a clearly arrhythmogenic syncope that is recent, which in real life would end up probably pushing us toward a defibrillator. If we use the risk factors according to the AHA risk stratification process, the risk of sudden cardiac death is still 0.85% per year. And something I just want to mention, because I think it's important in clinical practice. So when HCM is diagnosed above 60, the risk of sudden cardiac death is much lower, 0.2% per year, which is lower than the cause of death from other causes that can happen above these ages. So then we can wonder which method is the best between the American and European method. And what we see, so kind of unsurprisingly, we see that Americans tend to implant more ICDs than European, but overall, the sudden cardiac death rate is the same and not very high. So basically, everyone is doing a great job. So which method should we use as Canadians? The answer is probably between the two and in the integration of these two methods. So that's what has been proposed in the CPU that has been published recently in Canada. And when we look at more recent iteration of the guidelines in Europe and North America, they tend to be involving both methods at the same time. So I think there's true in the two methods, and integrating these two is the best way to go. Moving on to the next topic, arrhythmogenic right ventricular cardiomyopathy. So before we end up with risk stratification in ARVC, the first step is to make sure we have the right diagnosis, which is often the difficult step, but it's not the topic of the presentation. So once we have the diagnosis of ARVC, next important step is knowing what type of ARVC we have. And we have come to the understanding more and more that genotype is very important. So the real classical ARVC, most of the time is caused by a gene called plakophilin-2 or PKP2. This really gives classical ARVC. And consequently, because it's so common, it's really driven all the literature. So when we read about ARVC as a whole, we should think that it's mostly describing PKP2 cardiomyopathy or plakophilin-2 cardiomyopathy. Some other genes seem to be pretty closely resembling PKP2, desmoglin and desmocolin and plakoglobin, so they seem to all be behaving the same way. But for example, desmoplakin or TMM43 don't behave the same way. They are different diseases and shouldn't be treated the same way. Because ARVC is associated with high risk of ventricular arrhythmia, there has been a lot of effort put in the past 10 years in trying to, or 20 years to try to find the predictors of ventricular arrhythmia, and the past 10 years into consensus and guidelines to try to know who should get or shouldn't get an ICD. So the main predictors, syncope, non-sustained VT, presence of dysfunction in the RV or the LV have been identified for a long time. Something that is very important and that we have come to know more in the past 5 years is the importance of PVCs on the Holter and non-sustained VT. So I love Holters in ARVC. I use them a lot for risk stratification. And more recently, the use of a risk calculator has been advocated in the recent guidelines by the ESC. So this risk calculator, similarly to HCM, incorporates the best risk factors we have for ARVC, which are younger age, male sex, the presence of a syncope, the number of PVCs on a 24-hour Holter, the number of leads with T-wave inversion, the presence of non-sustained VT, and the right ventricular ejection fraction. So, for example, left ventricular ejection fraction did not stay in the model because it was not significant and probably not common enough in that largely PKP2-driven population. Again, same as for HCM, Americans, and in this case, North American, because Canada was behaving similarly to United States, tend to implant more ICD than what they do in Europe for a similar level of risk. Next question that can come, and this is also true for HCM, is if we should favor the implantation of a transvenous ICD or of the newer types, the sub-Q ICD. I would say most of the time for ARVC, especially in young patients that haven't had sustained VT that could be amenable to ATP, I tend to favor the implantation of a sub-Q ICD if they are young. And same for HCM if they pass the screening. However, in patients, especially with ARVC that have had prior sustained ventricular arrhythmia that are slow enough to be amenable to ATP, we should think about a transvenous ICD. Then what do we do once someone has ventricular arrhythmia in ARVC, sustained ventricular arrhythmia? So one treatment that is specific to ARVC is exercise restriction, which has really been shown to decrease the rate of ventricular arrhythmia. Then medication. So all patients, so it's been recommended in the guidelines to put everyone with ARVC on a beta blocker. However, I agree the data supporting that is very soft. Flecainide is the antiarrhythmic drug the most studied for ARVC, especially for PKP2. We have animal data, we have human data, which is, of course, mostly retrospective, but even one small prospective randomized trial that has been shown in an abstract 2 years ago, but we still don't have the publication. It is useful and well tolerated, both for sustained ventricular arrhythmia and for symptomatic PVCs. And I would say most of us in the community of people treating ARVC patients feel comfortable in patients with ICD, but not really comfortable giving flecainide in these patients without an ICD. Sotalol can be useful, but the data is kind of a little bit controversial towards if it works or not, but it could be tried. And we try to stay far from amiodarone in young patients, unless we really have to give it. Ablation is not an alternative to an ICD for sudden cardiac death prevention. However, there is some debate in some countries, mainly France, if patients with sustained stable ventricular arrhythmia could have a VT ablation instead of an ICD, but that's not the practice or the norm in North America. Treatment of VT of failure of antiarrhythmic drugs. Some would advocate going there as a first line, but that's not what we usually do. It works for sustained ventricular arrhythmia. We don't go there for PVCs. Often requires epicardial ablation, which has more complication, but less recurrences in this disease. And it is a complex procedure, so it has to be kept in good hands and experienced people. Next topic, high-risk non-ischemic cardiomyopathy. I would say genetically, there are two different types of non-ischemic cardiomyopathy, the high-risk ones and the garden variety or normal ones. So we've come to know, especially in the past 5 or 10 years, more and more genes that are associated with specific characteristics, mostly higher risk of ventricular arrhythmia, versus the other ones that are genes that pretty much don't really give a high risk of ventricular arrhythmia and for whom we should use the normal threshold for implantation of an ICD. So currently we use 35% in lack of having a better way to risk stratify these patients. And the recognition of these arrhythmogenic genes is important because they really behave different. They're associated with more ventricular arrhythmia and sometimes a worse prognosis or AV block. So one first gene that I want to talk about. So this was a 35-year-old woman who initially presented in the ER for a syncope, was discharged home with a diagnosis of anxiety and came back for an echography a couple of months later. So you see the ECG looks sick. The voltages are small. There is T-wave inversion all across the precordium. So this is very typical of something. And the CMR was also very typical. So LVEF is down, but there is extensive subepicardial late gadolinium enhancement. And the right ventricle has major criteria for ARVC. So this is very classical desmoplakin cardiomyopathy. Desmoplakin cardiomyopathy. So this subepicardial late gadolinium enhancement, especially when it takes multiple segments, is a hallmark. And it is also seen with filament C, which is another arrhythmogenic gene. So if you have that description in an MRI report, you should think that the patient might be at high risk of ventricular arrhythmia and should have genetic testing. At Montreal Heart Institute, this is kind of so classical that people reading the MRI, which we often have, well, most of the time have before we have the results of genetic testing, call out that this might be desmoplakin cardiomyopathy. 10 to 30% of these patients have myocarditis. 30% have a diagnosis of ARVC, but the risk calculator for ARVC doesn't work in these patients. This is a different cardiomyopathy. And as you can see in the predictors, this time it's not male sex, it's female sex. That's a higher risk. Non-sustained VT, PVCs are still important. The Holter is a good exam. LVEF decrease is important here, while it was not for ARVC, and a moderate to severe RV dysfunction. Another type of cardiomyopathy, so this is a man with shortness of breath. LVEF is 45%. He has had atrial flutter, known for non-sustained VT, and has a family history with a father who had severe DCM, atrial fibrillation, ventricular tachycardia, and a massive stroke. And what we see on the ECG is a very long first-degree AV block, but also some Wenke backing just on a 12-lead ECG. The QRS doesn't look normal, but it's neither a right or left bundle branch block. So this is pretty classical Lamin cardiomyopathy. So why should we care about Lamin cardiomyopathy? Well, first, it's not that rare. It's the second most common gene associated with dilated cardiomyopathy after the Gordon variety Titan. It is a progressive and aggressive cardiomyopathy. 20% of patients will have sustained ventricular arrhythmia, 20% will have terminal heart failure, 30 to 40% complete AV block, and atrial fibrillation is super common with a higher risk of stroke. The first thing about Lamin cardiomyopathy is to think about it. So any combination of AV block in young people, strong family history, ventricular tachycardia out of proportion of the LV dysfunction, AFib and sinus node dysfunction associated with LV dysfunction in young people, neuromuscular disease associated with heart involvement. So we should be thinking about it. At Montreal Heart Institute, we have, so this is so important, the management of patient, then when we are going to do a procedure in a patient, either a pacemaker, an ICD implantation, and knowing that it's a Lamin cardiomyopathy would change what we do or type of device we implant. We do the sequencing urgently in less than 48 hours so that we have the result and decide on the right device for the patient. So again, here, risk predictions and risk stratification is not easy as a cutoff of 35%. There are different identified predictors that we can use. So the fact to have lower ejection fraction, less than 45%, male sex and non-missense variants are predictors, but are less consistent. What a non-missense variant means is that it's not only a change of one amino acid for another one when we do genetic testing, it's anything that basically cuts the protein short. So that's a risk factor. Non-sustained VT is a risk factor, and AV block, any degree, is also a risk factor. So having a combination of different risk factors increases the risk. And there has also been a publication of a risk calculator specifically for patients with Lamin cardiomyopathy. So now, what do we do if a pacemaker is needed in these patients? So since conduction system disease is a strong predictor of ventricular arrhythmia, we should implant an ICD directly in these patients rather than just a pacemaker with no ICD capabilities. And same thing for ICD implantation. If we implant an ICD, we should have an ICD with pacing capabilities because we know that the risk of block is pretty high or bradycardia. And we should choose a device. So we should be more proactive in the use of resynchronization. So for example, the patient that I showed with an ECG where we suspect that he will be paced all the time and has a 45% ejection fraction, I will go ahead and resynchronize either with a normal CRT or a left bundle branch pacing. What do guidelines say? So the combination of the risk factors, the risk factors that have been found, non-sustained VT, LV, decrease in LVEF, male sex, non-missense variance. So more than 2 risk factors are an indication for an ICD. If a pacemaker is needed, or more recently, using the risk calculator associated with some of the stronger predictors. So how does ventricular tachycardia ablation works in LMNA? Well, not very good, low success rate, lots of recurrences, and lots of death or transplant. So when you're starting to think about VT ablation in these patients, you should refer for an evaluation for a transplant, probably, depending on who the... These are 2 genes with higher risk of ventricular arrhythmia. There are other genes that I won't discuss in detail, but you should maybe recognize these names because they have different way to risk stratify. Filament C, TMEM43, for which we have a founder effect in Newfoundland, Canada, PLN, and RBM20. Quickly talking about atrial fibrillation. So for HCM, it is pretty common, so we should look for it and suspect it because it's a high risk of stroke and everyone with AFib and HCM should be anticoagulated. Rhythm control is preferred because these patients tolerate poorly the lack of atrial kick. Antiarrhythmic drugs, sotalol, and specifically for that, disopyramide, which we use for a reduction in the gradient. So there's a lot of experience in disopyramide in HCM. And going for ablation earlier in these patients before we get to persistent atrial fibrillation is also a good practice. So think about referring these patients for management of their atrial fibrillation. Genetic left-sided cardiomyopathy, genetic DCM. So usually we anticoagulate if there's a decrease in LVEF or a CHADS 65 more or equal to 1. But I would say in Lamin cardiomyopathy, and as a team, we do anticoagulate regardless of LVEF. There's clearly an atrial myopathy that increases the risk of stroke. So that's kind of our practice. It's in one of the guidelines, not all the guidelines, but that's what we tend to do in these patients. And rhythm control is pretty usual. Atrial fibrillation is not usual in the RVC, and the management is not really different to what we do usually. So in conclusion, treatment of arrhythmia and genetic cardiomyopathy. So first important thing, prediction and prevention of sudden cardiac death. HCM, I think integration of the 2 types of management guidelines is the best. ARVC risk prediction model, and I think the importance of Holter is really there. In non-ischemic cardiomyopathy, I think we should recognize these red flags, especially because they're most common Lamin and desmoplakin cardiomyopathy. For ventricular arrhythmia, ARVC, flecainide is a good choice. Ablation is good. Lamin, ablation is not super useful. VT is usually a bad and a late sign. And atrial fibrillation, anticoag in all HCM patient, and I will say also Lamin patient. Thank you very much for your attention.
That was really as expected, Julia. Superb overview. So I'll open up to the floor for any questions.
Yeah, so maybe just to remind the people in the audience, because some people I think joined late. If you have a question, please type it in the chat, and we will try to get to your questions. We have about 9 minutes for questions, and I don't see any now, but maybe while we're waiting, Julia, can you, obviously my bias is imaging, and I know you had a slide about hypertrophic cardiomyopathy, about risk stratifying hypertrophic cardiomyopathy. It's CMR, SCAR analysis has, I think, fallen a little bit out of favor. So can you briefly touch on, which genetic cardiomyopathies you think imaging and maybe CMR has a role? Because in the latest ESC guidelines, they basically recommend a CMR for everybody with a cardiomyopathy. So what's your practice with using imaging to help guide risk management?
So that's a very good question. So I personally do use it quite a lot. So I think if I'm going through quickly the presentation in my mind, I think all the diseases I mentioned, I perform, well, I don't perform it myself. I'm not an imager, but I order a CMR. I think it is very useful. For HCM, so we don't use necessarily late gadolinium enhancement as a single factor, but it's used to risk stratify just with the rest of the risk prediction that we know to risk stratify patients. For ARVC, well, it's used for the imaging and the function of the right ventricle, mostly for the risk stratification at the beginning. So when we want to decide on implanting an ICD, usually for follow-up, when we have already decided that someone needed an ICD and we have the right ventricular ejection fraction at baseline, we don't necessarily tend to repeat. The other interesting thing for ARVC is that we can see if there is some left ventricular involvement, because we can see some late gadolinium enhancement on the LV, which is the earliest sign that we see in these patients without necessarily a decrease in left ventricular ejection fraction. For desmoplastic cardiomyopathy, I think it's a good diagnostic test because it helps us know who should get genetic testing. So if we have someone with non-ischemic cardiomyopathy and we do the CMR and we see this kind of subepicardial late gadolinium enhancement, I think this should bring us to genetic testing to look specifically for desmoplakin, but also for filament C, and then maybe change what we would do about the implantation of an ICD. And there's more and more data showing that in non-ischemic cardiomyopathy, so now thinking about the garden variety cardiomyopathy that I didn't really talk about. So if we don't have the genetic testing, so more late gadolinium enhancement, and especially in high-risk territories, such as subepicardial left ventricular late GAD enhancement is a higher risk of ventricular arrhythmia. So that is also something we take into consideration when people are borderline to receive an ICD. I think this is part of what we think about in our decision-making process. And I think so there should be more research. I think this will be integrated more and more in refining who needs an ICD in the future.
There are two questions, Julia, in the chat. The first one, I'll actually read them both out and you can answer them both. The first one is from the BARTS team in the UK. Thanks for the great talk. Do you routinely anticoagulate HOCM in the absence of AF? In the absence of AF, if left atrial dimension is greater than 50 millimeter?
It's a great question. I don't do it personally unless there's atrial fibrillation or an aneurysm. So I don't anticoagulate them, but this is probably a non-answered question. Maybe, so to my knowledge, it's not been studied, but maybe it's something we'll do in the future. But for now, it's not my regular practice.
And the other one,
I would look more aggressively for atrial fibrillation in these cases.
Right. And the second question is from Sinella Music here in Ottawa. Overall, in the patient population of non-ischemic cardiomyopathy, based on the current lines, do you think we are overusing ICDs and perhaps underusing it in more specific populations?
Yeah, that's also a great question and a great point. I think the question about overusing ICD is always tough because it's the kind of thing where how do you put in the balance like a risk of complication versus a risk of sudden cardiac death? So it's very hard, and probably depends from patient to patient. We have had a nice the Danish study already in 2016. I was about to say recent, but it's becoming less recent, showing basically that we're not doing a super great job in risk stratifying patient as a whole in non-ischemic cardiomyopathy. So I think as a whole, we put too many ICDs, probably too many ICDs in the older population that have more of a mixed disease and have a higher risk, a higher competing risk of dying from something else. So the defibrillator doesn't change much in their overall mortality, and I think that's part of the problem. But we are probably still lacking a bit of granularity and a way to target better patients who should need an ICD. So I think that's a big interesting aspect of research in the future, and that's part of my research interest for Canada in the next few years with the CRHR grant we had for a Canadian registry for risk stratification in non-ischemic cardiomyopathy.
Do we have time for more, Ian?
Yeah, I think we have a couple more minutes. One person's asking, Julia, anticoagulation. You mentioned briefly in one of your answers, you anticoagulate HCM with apical aneurysm without thrombus. Is that something you do?
Yes, I tend to anticoagulate when there's an aneurysm.
Okay. And then Dr. Swigum in Victoria is asking, in patients with non-ischemic cardiomyopathy that have LGE, do you do serial testing? Like for sarcoid, would you do serial? Maybe this is a question more for David. Serial PET, would you do? And I'll just mention one thing. So you mentioned in some cases you're doing subcutaneous ICDs. Those are terrible for CMR. Like they're right next to the heart, so we can't get any images. So we can't do serial scans on those patients, unfortunately, unless you tell me you can move it to the right side or something. But it's very hard to get in. So I'm just putting that out there. So yeah, do you get serial testing, serial imaging? What's your approach with serial measurements?
So it depends. So about the PET scan, I think the question of the PET scan is often ruling out or ruling in a sarcoid as a cause of late gadolinium enhancement. So about that specific part, I think I see David smiling, and he's way more a specialist of sarcoid than I am. So do you have something to say, David?
Yeah, no, we often do it. It's almost always negative. Sarcoid usually presents differently than that, but we usually do it just to be sure. And occasionally we pick up somebody with active sarcoid. We can never say that they don't have inactive sarcoid, but we don't. If the PET is negative, we don't repeat it again later on. It's extremely rare for sarcoid to come back again if it's burnt out.
Yeah, so you would tend to repeat it just to assess response to therapy in people with metabolically active.
Exactly. So if the disease is burnt out, then we don't repeat it. And I see a clarification from Liz saying clarification one after the other or at the same time. She's really asking, do we do the PET at the same time as the genetic testing?
Do we do so? It really depends on the initial presentation. So if we have our PET scan threshold is pretty low, especially when a patient is hospitalized. And so if we have a suspicion, for example, if we're wondering about lamin because we have an AV block and some VT, well, we're also going to exclude sarcoidosis for sure.
Okay. Thanks very much, Julia. I think we're going to move on to the next speaker, but excellent talk.
Yep, thank you.
Okay, I'll introduce our next talk is actually a debate, and we had this format last year. It was very well received, so we said, let's try the same format. So the debate question is, vigorous exercise is safe in patients with genetic aortopathy? And in a moment, we'll be hearing the pro argument from Dr. Mark Haykowsky, and representing the con argument is Dr. Siddharth Prakash. And I'll just quickly introduce both speakers. So Dr. Mark Haykowsky is a basic scientist, professor, and endowed research chair in aging, and he's director of an integrated cardiovascular physiology and rehab lab. He's at the University of Alberta. He's in the College of Health Sciences and Faculty of Nursing. And so his research interests have largely delved into looking at, excuse me, what are the causes for poor cardiovascular health and fitness, excuse me, and across the aging continuum. And so really he has a lot of experience in exercise intervention, exercise studies, and he has a recent interest in aortopathy. So we'll hear about some of his research and some of his views on that with the pro argument. The con side is Dr. Siddharth Prakash, who's a cardiologist, professor of medicine in the Department of Internal Medicine at McGovern Medical School at UT Health Houston. He has clinical and research interests in congenital heart disease and genetic causes of bicuspid aortic valve, as well as Turner syndrome and aortopathy. So he is really representing the clinical side and brings a lot of genetic expertise into the discussion. He sees a lot of patients with genetic aortopathy and will be able to provide us with that context as well. And so with that, I welcome Dr. Haykowsky to provide us with the pro argument for why vigorous exercise is safe in patients with genetic aortopathy.
All right, thanks, Ian. And can you hear me okay? Sorry, I can't see anything, but
Yeah, we hear you good. Yeah.
Okay, great. Well, thanks for the invitation to speak. And Dr. Prakash and I have met previously, so I'm not so sure, Ian, if it's the debate you want, because I'm not sure that there's a right answer, but I'll do my best. So should we do vigorous exercise with our genetic or aortopathy patients? And I guess I have the pro side, and it's pro with some caveats. I can say that at the outset. Okay. So just as a background, some of you may or may not know, but the most recent international guidelines recommend that our aortopathy patients perform light or mild to moderate aerobic exercise around 3 to 5 METs. And for those who aren't familiar with those terms, 1 MET is just your resting energy expenditure right now listening to me speak. So 3 to 5 times that for around 30 to 60 minutes, 3 or 4 days a week to avoid heavy lifting with Valsalva. And I would qualify by saying you shouldn't do a phase 2 to 4 Valsalva, but and we don't have time to debate this, but phase 1, I don't think is a problem. The trouble with these guidelines is that they're based on expert opinion, which is fine, but there actually is no robust physiological evidence at all to say that you can't do vigorous exercise because it's never been studied. It's just, let's just say, do mild to moderate. But I can say right at the outset, this is contextual. So as a result of these limitations, we have no data. We have some data that I'll show a little bit measuring aortic wall stress during exercise in aortopathy patients, but how can you confidently restrict patients from vigorous exercise without really knowing what the safe limits are? The trouble with this one-size-fits-all approach, it's inadequate, potentially harmful. It's overly restrictive, I would say, for about a third of our patients. It's potentially unsafe for another third, and this mild to moderate exercise is probably okay for the remaining of our aortopathy patients. So again, it's vigorous exercises contextual, and I'll show that in a second here. So I've just as again as an aside, master athletes, so older athletes who've trained, for their whole life in endurance sport, it's very rare to see any young athlete with clinically relevant aortic dilation. However, we do see, and so do others, about 20% of master athletes who are older have clinically relevant aortic dilation. And when we study these individuals are very fit, and people all talk about roughly have all been at the Olympics or the World Championships from Australia. But our post-aortic dissection, so they have now VO2s of about 25, 26 mils per kg, which is pretty low. And our aortic aneurysm patients, somewhere around 19, very, very, very low. So this slide is just showing your maximum metabolic equivalence with varying levels of exercise intensity. And then on the y-axis, just rest 25, 50, and 100 watts. So what's again, why I say it's contextual, because for the very deconditioned genetic aortopathy patient, just sitting at rest is 20% of their peak. So that's very light exercise, and they haven't done anything. At 25 watts, which is an absolute very, 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 very low workload, it's moderate for these patients. So just living, doing housework, walking up a flight of stairs, playing, making your bed and walking slowly is actually near maximal or vigorous exercise. So if you're going to counsel your very deconditioned people not to do any vigorous exercise when they have very, very low peak VO2s, then they shouldn't do housework, they shouldn't walk, they shouldn't go get their mail. You have to live. Um, Whereas our master athletes, when they would do 50 to 100 watts, that's very, very low. They're actually bored at that workload. So again, you have to individualize, and I think Dr. Prakash and I agree on that. You have to individualize the person in front of you. Um, so yes, some people can do vigorous exercise, and it's all relative. Some do vigorous exercise. They're walking anaerobes just to live in their instrumental and activity days of living. Um, but again, you have to look at the context. Also, we because no one's really measured wall stress until a paper that's going to come out shortly with our group, we're measuring blood pressure, which is great. But you also have to know about the aortic geometry. And this is just a slide from my colleague Andre Lagersh, a very nice slide showing that aerobic exercise, which we say is fine, is more of a pressure overload than anyone ever thinks. So even at low workloads, again, for those individuals who are very deconditioned at around 50, 75 watts, you can get pressures of 240, 250. So that's kind of worrisome for me, because if you're generating 250 at 50 watts, that's troublesome. Unlike the master athlete who might go to 3, 400, and the younger athlete to 500, 600 watts, they don't worry so much at a pressure of 500, even if they had some clinically relevant dilation, because their cardiac output is the cause of their blood pressure being high. That's 35, 40 liters per minute. Whereas the older aortopathy patient, or as I said to Dr. Prakash the other day, I'm actually more worried about the healthy controls we've brought into our lab who aren't blood pressure controlled. I think they're a greater risk for any sudden event as opposed to our very well-controlled blood pressure aortopathy patients. But if your blood pressure workload or cardiac output slope is very high at a very low workload, you probably should be doing exercise vigorously. However, that still could be living. So again, just I think we need to prescribe exercise based on your aortic wall stress. Kind of hard to do, but we've done it. This is just Laplace law that everyone's familiar with that I won't go into. But if you know the geometry of blood pressure in these two scenarios, I've given the same blood pressure, but one aortopathy group has some thinning wall. And I'll qualify by all the measurements that we've done. I know nothing about the material properties of that aorta, so caution is warranted when you don't know anything about that. But at the same blood pressure with dilation or aneurysmal aorta and a thin wall, the wall stress is threefold higher already at rest. So why is this important? Well, the aortas will rupture, and how they do this biomechanically is they get a piece of aortic tissue, and this is a biaxial aortic stress, looking at stress strain and Young's elastic modulus, as well as the maximal tensile strength. And this is basically your MR echo equivalent of measuring strain in the aorta with a little 4x4 piece of aortic tissue, and they'll look at this maximal tensile strength and its creep and when it will rupture. And based on this data, Vorp et al. And John Leftriadis and others have demonstrated that in a healthy aorta, or as healthy as the aorta can be, that's going for some valve surgery and they have some tissue, but no aortopathy, it's around 1,700 to 2,000 kilopascals is the rupture threshold for a healthy aorta, and it's around 850 to 1,200 in an aneurysmal tissue. So that's kind of our base point that we have to look at. Don't have time to show this, but we only do exercise MR, and in real time we do ungated free breathing MR, where we can measure cardiac output during exercise from rest all the way to maximal exercise. With the septometry, you can measure VO2. We do some advanced imaging. Well, it's not really that advanced, but the advanced post-processing where we look at the aortic diameters. We measure that rest during exercise. We measure aortic diameter during exercise, and then we back calculate aortic wall thickness with conservation of mass and blood being incompressible. And now, knowing your blood pressure and geometry, we actually, for the first time, have measured aortic wall stress when you exercise. This is just some data, and again, I've made some imputations, but I will show you some data for the master athletes. Again, these are 29 that have clinically relevant aortic dilation over 4 centimeters versus master athletes without that. They're very, very fit. They've all been to the Olympics representing Australia at the World Championships or Olympic medal holders, and now they're retired but still training. And this is just some of their metrics that we won't really get into. What's fascinating is that the younger athlete obviously has cardiac remodeling, and we do see that. So does the master athlete older, but the young athlete at the Olympic level doesn't have clinically relevant aortic dilation. But the older master athlete, about 20% can. So what do we do with these individuals? It's kind of a great question. These people are doing vigorous exercise. So here's just the imputation of peak aortic wall stress with the systolic blood pressure from a maximal test with the resting diameter. We assume it doesn't change much, and we actually find it doesn't during exercise, even in aortopathy, as well as wall thickness. So compared to rest, the wall stress is 160. It goes up by 81 kilopascals to 250, even in these elite athletes, which is nowhere near the rupture threshold of 2000. And their aortic wall stress, power output, or cardiac output slope, we call that aortic mechanical efficiency, is very favorable. Here's three of our aortic aneurysm patients. They're very interesting. They're not, again, this aortic paradox. It's not really a paradox. It depends how thin your wall is. We have one of our aneurysm patients who kind of looks like a normal master athlete as far as their slopes, whereas those other two have markedly higher aortic wall stress because their walls are thinner at the same blood pressure and a greater diameter. If you look at the right, though, this kind of worries me because it's our measure of aortic mechanical efficiency at low workloads. And what it's suggesting is that at 50, 70 watts, is that the slope of wall stress to cardiac output is very, very high. So could some of these people do some vigorous exercise, and do they do this in their ADLs? Probably, but you kind of have to be a little bit worried potentially. However, remember, it's 1,250 kilopascals, 850 to 1,200 that ruptures aortas. Not that I know what their tensile strength is, but we're still nowhere near that value. Here's just some data because I think I'm getting close to my 10 minutes where we've got, this is now light to moderate, and then we've also put peak aortic wall stress. We've done a few imputations. You'll see right in the light pink is our aortic aneurysm patients, and even there, some variability of these three, but our highest is 450, our lowest is 200, and the post-aortic dissection repair, they're fine. They're probably got a lower wall stress than me giving this talk right now, so around 200 kilopascals. So again, early days, but we are testing a lot more. Dr. Prakash is the world leader in exercise training aortopathy, and I'm sure some of his people are doing vigorous exercise, especially if they're very deconditioned, but we do have to individualize. Finally, who shouldn't do vigorous exercise? Why don't we do that? Well, this is just some machine learning and artificial intelligence that I've done because I'm not smart enough. And basically, this is some imputation if your aortic diameter is clinically relevant at 5 centimeters or 5 centimeters. And then I've imputed some wall thicknesses with varying blood pressures. If you have a very thin wall, 0.7, 0.6, 0.5 with 45 millimeter, and especially even almost less than 1 millimeter with a pressure of 140 to 160, you actually can reach that magical threshold. So those individuals who've got this translucent aorta very thin or this big diameter, 6 centimeters, obviously they're going for surgery. They worry me. I don't even think they should be doing exercise. And I can't believe I'm saying that because I believe everyone should. But if you've got that very thin wall aorta and a very dilated diameter, you need to have your surgery and then you should do your rehab. But these patients do worry me. Last slide I'll just show us, well, what do you do with the 80-year-old triathlete who's at 75 years of age? 65 years of age. He had many risk factors and decided to start doing exercise, and like everyone else, seems the entry level is a marathon or triathlons, because if you got a lot of money, you can buy a nice bike, and swimming's not very hard if you're heavy, and riding a bike's not very hard if you're heavy. It's just when you see these people running who are out of shape, they're pretty slow. This individual started doing, I think he's done 44 half Ironmans, but at 75, just sort of incidentally, they found he had an aortic aneurysm, 5.2 centimeters. He's been very keen to measure his blood pressure over the last 5 years. He's had a number of MR, CT, and echo assessments of his aorta, and basically this individual's aorta hasn't changed over 5 years, and I've imputed his wall stress. So you have to remember, even if you do some vigorous exercise, which is contextual, for the hour that you do the exercise to 2 hours, if you're a master athlete, you have 20 to 22 hours of the day where your wall stress is lower than you or I listening to this talk because you have vascular favorable function. So you have to put it all in perspective as far as risks. So in summary, aortic wall stress during exercise in health and aortopathy in our hands, it's well below the maximal tensile strength. Caution is warranted if you don't know the material properties. Should older master athletes with a dilated aorta stop vigorous exercise training? They're not going to, but you can have shared decision-making models. It's well below the threshold for rupture. And again, the benefits of exercise in the 24 hours, 22 to 23 hours that you're not exercising outweigh the risks, I think, during acutely. Exercise guidelines absolutely need to be rewritten. They will be with data that we're publishing and Dr. Prakash, who's doing exercise training, but it's all contextual, it's all relevant. And if you again encourage people not to do any vigorous exercise or decondition, then again, they can't garden, they can't housework, they can't carry their children, they can't walk upstairs because deconditioned people are doing vigorous exercise or activity to survive in their ADLs. So I look forward to Dr. Prakash's talk because, again, as I said, he's a leader in exercise in this field. Thanks, Ian.
Thanks, Mark. Okay, and with that, we'll hear the con argument from Dr. Prakash.
Great. May I share my slides? There we go. So thank you to Dr. Paterson and the team at Ottawa Heart for inviting me. This is a tremendous honor, and I'm grateful to participate in this debate. I'm funded partially by the John Ritter Foundation for Aortic Health and the Genetic Aortic Disorders Association Canada, which supported part of this work today. So when we're talking about heritable aortopathies or genetic aortopathies, to be clear, we're talking about Marfan syndrome, Loeys-Dietz syndrome, familial thoracic aortic aneurysms and dissections caused by various single gene mutations. And as the cardiologist in our aortopathy clinic in Houston, my most frequent question from patients is exercise dilemmas. Specifically, what types of exercise are safe and how much exercise is too much? And the dilemmas come from the fact, as Dr. Haykowsky mentioned, that the guidelines are very restrictive and that exercise could theoretically be dangerous to people with aneurysms and dissections due to the mechanical stress and blood pressure increases during exercise. And particularly, I work with a lot of patients that are susceptible to tears in the aorta or aortic dissections, which is when a flap opens up and actually rips through the aortic wall. Many of them live chronically with this condition. And of course, we talked about the aneurysm. So these are different conditions and they have profound changes in the structure of the aortic wall. And when we talk about moderate aerobic exercise, the kind that most of us perform, we're typically talking about a running activity where systolic blood pressure increases gradually at first and then plateaus. We can readily measure this during aerobic exercise through treadmill testing. It provides opportunities to adjust the intensity of the exercise before you reach the threshold blood pressure that you're concerned about. Typically, in healthy individuals, the systolics will reach between 150 and 170 millimeters of mercury and then drop after exercise quite promptly. However, this increase may not be predictable from their resting blood pressure, which is a point I'll get back to later. Now, when we talk about intense or vigorous aerobic exercise, what I'm plotting here on the right is the Borg effort. So this is the individual's rate of perceived exertion scale from 0, doing nothing, to 10, the hardest exercise they can imagine doing. So that's being plotted in blue, and you can see that as intensity ramps up, there is a fundamental shift in the way blood pressure responds to exercise, where there is a plateau at steady state. As you get to the right of the curve, you see a dramatic rise in systolic blood pressure. Diastolic blood pressure remains mostly unchanged. And so this dashed line at 165 has previously been shown to be predictive of all-cause cardiovascular mortality in individuals who perform exercise stress tests. So that's why I'm pointing it there. And you can see that as you near exhaustion, even healthy individuals can cross this line. So the question here is, what causes this to shift to the left? And can we predict that and keep our patients safe when they reach vigorous exercise? So the physiology behind this has to do with the changes in cardiac output, total peripheral resistance, and stroke volume during exercise. So again, I'm plotting effort here in a blue. Cardiac output, you can see in orange. And the thing about cardiac output that is surprising is that although it increases steeply at the beginning of exercise, you reach a point where cardiac output plateaus and drops off. And this is because stroke volume then also decreases as heart rate increases, and your total cardiac output towards the right of this curve becomes increasingly dependent on your heart rate. When that happens, there is vasoconstriction, so that the relative decrease in peripheral resistance begins to slow in terms of a decreased slope of that curve, and you reach a maladaptive threshold where there's increased sympathetic tone, relative vasoconstriction, and this is reflected in increased troponins and brain natriuretic peptide levels, which can be detectable for up to 24 hours after a vigorous exercise is completed. So this suggests that in the short term, while this may be, you may be protected, chronic exposure to these conditions can induce vascular and cardiac damage. And indeed, we see that in patients that are exposed to these conditions, even master athletes. So if you add in a chronic disease like hypertension, relatively common, what you do is essentially shift the curves to the left so that now during exercise, you have a larger hypertensive burden, a longer period in the threshold, over the threshold, and that the blood pressure slopes increase with effort so that you can get truly very large increases in blood pressure at lower levels of effort, as Dr. Haykowsky showed. And so this indicates that with deconditioning and hypertension, the combination can be synergistic and pose a severe risk to individuals who attempt to engage in vigorous activities. Finally, and you can see these exaggerated responses in terms of a prolonged period over 170 systolic that is not predictable from their baseline blood pressure. We've showed again that this is predictive of future cardiovascular mortality. It's independent of other established cardiovascular risk factors. And you also see a profound drop in blood pressure after exercise, which can cause syncope or pre-syncopal episodes. And we found that's true in our athletes with aortic disease. When you look at the risk factors for such an exaggerated blood pressure response, it is variably defined, but generally between 190 and 225 systolic blood pressure during exercise, depending on which society you look at. A lot of our aortopathy patients check these boxes. So there are genetic variants that affect the aortic wall, as I mentioned. There's to proceed from an earlier age, and there's also impairment of arterial barrel reflex hypersensitivity, which can also exacerbate the response to both systolic hypertension during exercise and post-exercise hypotension. So we think that our population is especially vulnerable to these effects. And the reason is that hypertension and underlying aortic pathology have additive effects over time. We know that if you look at the aorta of a hypertensive person, it becomes thickened due to replacement of normal smooth muscle and elastin with collagen. And this is the same process that we see in an accelerated way in individuals with heritable aortopathies. Their aortic histology looks similar. And in fact, there is a feedback loop where increased hypertension leads to increased arterial stiffness and adds to cumulative damage to the aortic wall over time, suggesting that these patients are on an accelerated course to develop this vulnerable phenotype. And then when we look at individuals who are on medications, medication blockers decrease VO2 max by 15%, and essentially they shift the curve again to the left by lowering the threshold for maximal effort when blood pressure can spike. You see the blood pressure curve shift left, the effort slope increases, and there is, and the other problem with individuals who are taking beta blocker medications is that their heart rate and other autonomic signs may not reflect the level of efforts. Beta blockers blunt the usual warning signs of overexertion and potentially contribute to overexertion. Finally, when you talk about resistant exercise, there's a very thin and very striking continuum between healthy and maladaptive responses. And this has to do with the phenomenon of stacking, where repetitions of repeated muscle contraction lead to progressive increases in blood pressure over time. And if there is insufficient pause between repetitions, you can get progressive changes in blood pressure. The diastolic blood pressure does not decrease as much in between repetitions, leading to a prolonged diastolic hypertension. And if you combine that with Dr. Haykowsky said, a Valsalva maneuver, EVAS phase 2 or 4, you can truly reach these large levels of afterload, which can be very devastating to an individual with underlying aortopathy condition. So in conclusion, vigorous exercise is risky. There may be large increases in systolic blood pressure due to increased cardiac output and vasoconstriction. The increase may not be predictable from the baseline blood pressure, leading to a false sense of security. The blood pressure increase may be larger in people with underlying hypertension or vascular disease, including aortopathies, and in untrained individuals. And medications such as beta blockers do not protect against such surges due to vigorous exercise. We know that over time, vigorous exercise can lead to myocardial and aortic fibrosis, as well as diastolic dysfunction and increased aortic stiffness, which tend to exacerbate these kinds of changes in response to exercise. And therefore, cardiovascular outcomes follow a U-shaped dose response curve to exercise. Vigorous or high levels of exercise may be deleterious, especially to these vulnerable populations. We think that they may be people with heritable aortopathies may be particularly prone to these kinds of responses, and exercise-induced vascular damage. It is really not well defined at this point, and there needs to be more research before we can conclude that high-intensity exercise is safe for this population. And I'd like to thank my sponsors, and there's my contact. Thank you.
Thank you, Dr. Prakash, and thank you, Dr. Haykowsky. So we have about 7 minutes for questions. That was a great debate, and I think you both have compelling arguments either way. It sounds like at the end of the day, both of you feel exercise is important for this patient population, but there maybe are some patients who should not be exercising. And it sounds like genetic aortopathy is particularly a high-risk group among the people with aortopathy. So I wanted to ask, both of you kind of alluded to this with your discussion around Valsalva maneuver. So are there particular types of exercise that you would view as particularly high risk? Let's say in athletes, are there some maneuvers where people will be valsalving more during vigorous exercise, for example? Is there sort of a double concern? I'll maybe ask each of you, Mark, and then Siddharth. Mark, what do you think?
Anything that we don't have time to show slides, but the importance is the transmural pressure. Anything that you will breath hold for more than 2 to 3 seconds will lead to phase 2 to 3, and then the 4, and you get an overshoot with vasoconstriction, as was mentioned, and the interthoracic pressure is not supporting the blood pressure. So you get this massive overshoot. So if you're going to do any weightlifting that holding your breath for 30 seconds, that's bad because you overshoot. Rowers, in the catch of rowing, we all do a breath hold. It's obligatory when you lift weights at 80% or above. We just say to people, do what comes naturally, but don't do it for too long. But Dr. Prakash caution is warranted, though, because most of the aortopathy patients in aneurysm we've studied were not the Marfan, the Loisy-Dietz. So the material properties are different. So we don't. So I am more cautious. But yeah, just 2 to 3 seconds, what comes naturally to stabilize your spine and abdomen, I think is okay because you're going to do that anyways. But you definitely want to avoid anything that is going to be prolonged.
Sorry, I just wanted to remind the audience that if they have a question, please type it in the Q&A section or the chat, and we'll get to your question.
But the paradox, Ian, is that the guidelines recommend that you don't do any, just light, but you can actually generate a pressure of 261, 280 doing an arm curl at 10 repetitions with no breath hold. The aorta sees that now. That's high. So we just have to be careful also taking healthy data that I have to apply to aneurysm. We don't know, but I don't know. I don't know what you think, Sid. We just say do it comes naturally. Don't do it for too long.
Yeah, so we've done several years of exercise testing on our patients. We actually do arm curls and we measure the blood pressure in the opposite arm. We supported the arm and we tested ways for them to free breathe and also have their arms supported so that they could do the curls without an increase in their systemic blood pressure. So it is possible, but it requires training and spotting and some careful instruction. And the same goes true for lifting light weights. They need to learn how to free breathe, and everyone tends to start out holding their breath. We can see these dramatic changes, but in most cases, if you give them feedback, they can figure it out pretty quickly. So we did an in-person exercise session. Then we would do video follow-ups with them at home where we would have them demonstrate using their home setup and just confirm that they were doing the same approach. And we were able to show that this is a safe approach for a year of people doing exercise. And I think that's something that's widely available to anyone because it doesn't require special equipment. It just requires knowledge. So I do think that with caution and with instruction, which I understand is always a problem due to time limitations, but it's not an expensive operation is the point. We can get people to be more active. And there is benefit to resistance training, which I didn't go into. It does actually, in moderation, lower blood pressure and is quite effective as a medication, as adding a medication to lower systemic blood pressure over time. So we do encourage our patients to do resistance training just within these parameters.
And Ian, just as an aside, it shocked me in doing this literature. What sport do you think that many aortic aneurysms rupture in? I don't know if it's a sport, but I guess it is. Golf. So, so why? Because
I was
golfers,
going to guess bowling.
yeah, bowling. I mean, golfers, they sit in the cart, they smoke, have a cigar, and then they drink beer, and then they're hypertensive and obese, and they swing, and but you can rupture an aneurysm in golfing. So, uh, don't
Yeah,
go.
most don't rupture during sports at all. So
That was going to be my question. Do we know when these patients tend to rupture? Like, do they rupture during activity, like genetic or
It's hard to how do you quantify the exact? Some people say they were lifting, but you don't know the time
yeah,
course. So,
yeah, we did an autopsy study of 125 people who died due to aortic dissections over a 10-year period. And the most common thing was they died during their sleep.
yeah,
So
exactly.
that's about the most relaxed anyone gets, and they're dying of a rupture. So
Yeah.
I don't think you can make any direct correlation between a specific activity level as a time point at a given time point and the risk of dissection. It's just impossible, like Dr. Haykowsky said, because most of the time you're living with a certain set of conditions that will predominate, and minute-to-minute changes don't really make a ripple in that.
we have one question from the audience. They want to know the effect of concurrent aortic valve disease. So if someone has aortic stenosis, or let's say aortic insufficiency, or an aortic valve replacement, does that alter your recommendation?
Yeah, so I can answer that quickly because my interest is in bicuspid aortic valve. And what we've found is that individuals with bicuspid aortic valve actually have a lower dissection and rupture risk. So it's a very positive prognostic factor. And I've been very liberal about letting my BAV patients exercise. Even after valve replacement, they're doing really well. I have several competitive athletes with BAV who've had valve replacements and are gone back to competition. And again, their aortas aren't changing. So I think that relative to tricuspid valves, they are protected.
I have one quick question. I enjoyed the debate very much. Do you think we should be doing an RCT and randomizing patients to different levels of exercise and looking at rates of aortic dilatation?
Absolutely. I mean, we've done a small multi-center trial with folks at Michigan and St. Louis, and part of the preliminary data was to show the safety and establish the protocol. But we absolutely are interested in collaborating with you and other people on a multi-center trial with a more sophisticated protocol. And an exercise physiologist like Dr. Haykowsky would be excellent for that.
You could do some sort of cluster crossover randomized trial with, very cheaply randomized centers to different or something like that. Yeah,
The trouble we have, David, is we don't do one. We train our patients like they're Olympic athletes. We periodize that. We give them intervals, we give them tempo, we give them
I
strength.
know.
So you'd have to have one center that basically is usual care is they don't get anything,
Yeah. Yes.
um, because I don't think you should be training with like high intensity and one is a continuous and one you need to do it all. But I do agree there needs to be some studies because like again, if the main thing is again deconditioned people living is vigorous activity because we forget that climbing a flight of stairs when you have very low fitness is near max effort.
Yeah.
Yeah, and a lot of their cardiologists are still unfortunately telling them not to exercise.
Correct.
So our whole trial was the point was, yeah, these people can exercise, they do well, they feel better, their mental health improves, and there were no dissections. So we are just trying to get that out there first because there was a lot of
Right.
skepticism from the community that I work in that
Yeah,
these people shouldn't be exercising. So we had to show that first.
yeah,
Yes.
I agree.
Okay, well, thanks for a great debate, and we look forward to you guys coming back in a couple of years and telling us that it's actually safe for these patients to be exercised.
Thank
Okay.
you.
Yeah, thanks, you too. That was very interesting. So we'll move on to the last speaker of the morning. I'm very pleased to introduce Daniel Reichart. Is a physician scientist at the University Hospital Munich and the Gene Center Munich, and he's done pioneering work focusing on the molecular phenotyping of cardiovascular disease and xenotransplantation using single cell technologies. Alongside advanced next generation CRISPR tools and heart failure research. And he's going to be talking to us about CRISPR gene editing and applications in cardiomyopathy. So thank you, Dr. Reichart, for taking the time to join us today.
Okay, I'm muted now. Many thanks for the kind introduction. I'm actually talking to you from Tokyo today. It's like later this night, later tonight already. But it's a pleasure to give some insights into like newer CRISPR gene editing tools and their applications in cardiomyopathies. And actually, I will walk you through like the main applications and actually also the main tools based on hypertrophic cardiomyopathy, which we heard already today, that is actually not meant to be like a rarer disease, but nevertheless, I think it's a good disease to really like work on these applications. I don't have any disclosures. As we heard already, the spectrum and heterogeneity of hypertrophic cardiomyopathy is huge. We have left ventricular hypertrophy normally. We have therefore also diminished left ventricular chamber volumes, and also we could see left ventricular outflow tract obstructions, as pointed out with this red arrow, which actually can cause severe dyspnea and symptoms in patients affected by this disease. Also, these patients do show on histology increased myocardial fibrosis and this very typical myocyte disarray, what we can see on the lower right. And that actually can cause actually overall a high rate of arrhythmias overall, an increased risk of sudden cardiac death, and also progressive heart failure. And we can see that actually the majority of patients, especially the athletes that experience sudden cardiac death, are actually caused by hypertrophic cardiomyopathies. And also, we should, as we heard already in the first talk today, avoid atrial fibrillations in all HCM patients as much as possible, but 20 to 30% actually experience that kind of arrhythmias. We know that in around about 40 to 60% of all patients, sarcomeric HCM is actually the cause for hypertrophic cardiomyopathy itself, but also the obstructive variant. And most of the variants are actually located in the myosin heavy chain 7 gene or in the myosin binding protein 3 gene, smaller portions in the thin filaments like troponin I or troponin T. And then, so that's called more or less like sarcomeric HCM, but we also have non-sarcomeric HCM, like caused by errors in the metabolism or associated with other neuromuscular diseases. But today I will focus on the sarcomeric HCM and their potential treatment using CRISPR tools. And as I said, normally it's said to be like a prevalence of 1 to 500, but nowadays we actually think that the prevalence is actually higher, to 1 to 200 to 1 to 300. So it's actually not a rare disease anymore. So the overall question that we had is actually, can genome editing be used to prevent sarcomeric HCM? And we there in the Seidman lab, where I did my postdoctoral fellowship from 2018 to 2021 with John and Cricket Seidman, we have this wonderful mouse model which actually has a very severe phenotype, where an R43Q variant of the myosin heavy chain 7 mutation gene was introduced, and it's an optimal mouse model to really study this monogenic hypertrophic cardiomyopathy and to optimize gene editing strategies. As I said, it has a high penetrance, not only in this mouse model, but also all patients who actually have that variant actually showed a high penetrance and very severe clinical phenotype, developing end-stage heart failure. Also, needing the need of heart transplantation was definitely apparent. It's a loss of function variant, so are actually well tolerated. So the PLI score is 0. So only half of the healthy myosin dosage is actually necessary to really have a proper heart function. And down here you can see that actually the mutation is a CAG, is actually a CAG, and that actually the amino acid is a glutamine. And actually at the end, using CRISPR tools, we want to actually end up with a wild types or an arginine down here. And down here you can see how severe the hypertrophy is, and all the blue in this meson trichrome staining actually represents heavy fibrosis, which actually then also causes higher burden of arrhythmias, for example. So since 2012, actually even before, we know that CRISPR-Cas9 is actually a very useful tool to modulate and gene and edit the DNA itself. It's currently the most flexible genome tool that we have in our hands, and we have 3 different versions. We have the plain nuclease, which actually cause double-strand breaks by the Cas9 enzyme. Then we have the base editor, which is the next evolution of the nucleases, which actually has an deaminase attached. The nickase is the nuclease is actually mutated, and this is why we call it a Cas nickase. So it only produces a single strand break. And then the newer kit on the block, introduced by David Liu in his lab at the Broad Institute, it's the prime editing, and actually it's also a mutated nuclease, also causing a single strand break, and the reverse transcriptase is attached. So actually any genome editing can happen in this regard. So as a first example, I want to go into the nuclease approach. As I said, the nuclease approach is let's say, more or less like the CRISPR 1.0 approach. So we have a double strand break caused by this Cas9 nuclease. And at the end, what we actually want to end up is we want to selectively inactivate the diseased allele of the this diseased R43Q allele within the myosin heavy chain 7 mutation gene. That means it's a heterozygous a mouse model. Removing that particular alleles enough to really avoid the disease. So at the end, we really want to disrupt the gene by insertion or deletions, and that's how the approach is. So here you can see the DNA, how it is, and we have that R43Q variant located in here, and we want to actually introduce, by using a double strand break, using this nucleases, Cas9 nuclease, a cut site, and that actually causes indels, so insertion or deletions, which actually then cause frameshift mutations, and this is why then you have a disruption of this whole allele. What we did is actually, and that's actually the beauty about this Cas9 nuclease approach, you can actually fit it in one AAV9 virus, so adeno-associated virus, 9, which is actually has a high affinity to the heart, and in this regard, we also use the S aureus version of the Cas9 to fit it into one AV. And the mice were injected between week 2 to 3. And then we followed them up to 33 weeks, and we did regular echocardiogram monitoring to see whether we could avoid the phenotypes or the hypertrophy of the heart. So overall, this is more or less like an off-the-shelf approach. So actually, any variant that's like located in the myosin heavy chain 7 mutation can actually be treated by this approach. This is like easily said because of course you have to somehow like navigate with the PAM sites that are located, and also the protospacer has to be well attached. With this approach, we were able to actually like inactivate this disease, so this R43Q allele, quite well. So in the left ventricle, we're able to inactivate up to 70% or even more of the diseased allele. In the RV, it's a little bit less. And also in the left and right atrium, it's a little bit less. The doses that we use are actually at the higher end, so 1 to 10 of the 13 vector genomes per kilogram. So it's rather at the higher end, but it's been used in that range in most of the studies so far. So looking at the phenotype itself, we're able, with this dosage of 1 to 13 vector genomes per kilogram, we're able to avoid the phenotype of left ventricular hypertrophy. So we measured the thickness of the posterior wall in this regard. So you can see it on the y-axis. And then on the x-axis, you see the age. So as I said, we followed them up to 32 weeks. So in blue, you see the treated mice, so the ones which actually receive the Cas9 nuclease. And in blue, you see the wild type. So, and in black, you see the wild type. So the wild type and the treated mice show like similar diameter of the left ventricular posterior wall, whereas the untreated R43Q mice are actually the ones which actually show like the hypertrophic cardiomyopathy phenotype, had like a tremendous increase of the posterior wall thickness, and the difference is actually significant between both. So we were able to actually avoid the hypertrophy and the phenotype of these mice, in these treated mice. Nevertheless, when we looked at the fraction shortening, so at the left ventricular function, we saw actually from the beginning on a decline of the heart function. And again, in blue, these are the treated mice. In black, you see the wild type mice, so no mutation was inserted in these mice. And then in red, you see the R43Q, so the hypertrophic cardiomyopathy mice. So you see preserved ejection fraction in these two groups, whereas in the treated mice, we saw a steep decline, and actually, which was also significant in this regard. So we're actually wondering why actually did we see like a resolvement of the phenotype, but a decline of the left ventricular ejection fraction, so the heart function. Why was it not preserved over time? So we did a dosage study. So as I said, the first dosage we used was 1 to the 10 of 13 vector genomes per kilogram. So rather a higher dose. So we titrated down to a medium and lower dose, as you can see down here. And this is actually like a no-brainer, right? The less you apply of the dosage, the less editing you achieve. So as I said, the first was like around about 70% in the left ventricle. If you go to the medium dose, you have around about 50% of editing in the left ventricle. And if you go even further down to low dose, you have like around about 20% of editing. So that's actually expected, right? But even like with a low and medium dose, so these bars in the middle here, we're able to more or less like prevent the left ventricular posterior wall thickness. So the phenotype of the hypertrophic cardiomyopathy. Why do I say like more or less? Because if you look at the low dose, we have actually one mice that actually escaped. So that low dose treated mice actually showed the phenotype of hypertrophic cardiomyopathy, whereas the other two actually showed no phenotype. In the medium dose, all 3 mice were showing no phenotype. In the high dose, as expected, no phenotype present, right? Looking at the left ventricular ejection fraction again, we do see the 3 dosage over here on the right side. The ejection fraction or the heart function was preserved in the low dose group, also in the medium dose, whereas in the high dose, again, we saw a decline of the ejection fraction. Actually, 1 mice died at the later stage during the experiment. So we're wondering actually what happened, and we saw. We did some more sequencing, and we looked at the unmodified R403Q allele. As a reminder, with this Cas9 approach, we try to modify, to delete basically this diseased allele. And we see, as expected, with the higher dose, so from low dose to medium dose to higher dose, we're able to inactivate the R403Q allele even at a higher stage. But also, if we went up to the high dose group, we actually modified also the other allele, so also the wild type allele. As a reminder, this mouse actually was a heterozygous mouse, so 1 mutated allele, 1 wild type allele, and we also cut with a higher dose unselectively actually also the wild type allele, and this was actually the cause why we see why we saw actually a decline of the heart function over time. So basically the dosage matters in this nuclease approach, and as a next step that I want to walk you through is actually the base editing step. The base editing step, base editing also developed by the David Liu lab at the Broad Institute in Boston. It's actually called also the CRISPR 2.0 approach. It actually corrects point mutation with increased efficiency and safety. So as a reminder, 60% of all disease-causing mutations are actually point mutations. And these deaminase, which is attached to the mutated nuclease, which is then called a Cas9 nickase, can actually mediate all 4 possible transition mutations. So C to T, and A to G, and T to C, and then G to A. As I said, the nuclease in this regard is mutated, so it causes only a single strand break, and that actually causes less off-target effects, where actually the European Medicine Agency, but also the FDA is always very worried about that you cause like off-target effects. And it has a high on-target efficiency, even in non-dividing cells, and that's, of course, like, as you know, I don't have to tell you, but it's very important in the cardiomyocytes, where actually we don't have a lot of non-dividing cells anymore. So again, you see the DNA with the mutation of in the location of the R403Q as the R403Q variant within the myosin heavy chain 7 gene. And we want to basically come back from an CAG to a CGG, so to the wild type version. And for that, we use the adenine base editor. So in this regard, we converted the adenine using the deamination step to an inosine, and then by a single strand break. As a reminder, this nickase only breaks 1 strand. And the following DNA replication and repair system, so the DNA always tries to repair itself as fast as possible. We're able to actually modify the also the opposite strand to an adenine to guanine result. The only downside is actually that any A that's actually within range of, let's say, it depends on what adenine base editor you're using, but let's say within 12 base pairs coming from the target side will be edited too. So, and in this regard, we actually had 2A here, as you can see at position A10 and A11. So you have to be aware that you can cause actually like mutations at that region. So, but that's a risk we took into account, and luckily we were able to go around this problem. So, as a reminder for the nuclease approach, so for the first approach that I've explained, we use only a single AAV. So that means you pack your whole package into one virus, and then you apply it into the you apply it systemically, and that's actually, of course, like only one AAV has to approach a cardiomyocyte. is slightly different to the adenine base editors, which actually are bigger because of due to the deaminase. The whole package is just like bigger, so you have to split the AAV and actually like the adenine base editors. So you have to use the split NTN approach using a dual AAV. That means really you have to be sure that both AAVs, which actually carry different parts of this adenine base editor, really approach the same cardiomyocyte. So we did a preliminary experiment where we added EGFP, so a green color, in one AAV, and in the other AAV we put the red color. So in this regard, M scarlet, and we looked at the merged image how many cardiomyocytes were actually infected by both viruses, and you can see in the reddish, yellowish part, actually all these cardiomyocytes were infected by both AAV. So we were actually confident that we would be able to approach many cardiomyocytes when we use this split NTN approach. And we're actually quite happy with the results. So using a single injection of dual AAV, AAE, that's the currently most efficient adenine base editor, we're able to correct the disease allele up to 80% in the left ventricle, a little bit less in the right ventricle, and even less in the left and right atrium. At a dosage, again, rather high, so 10 to the 13 vector genomes per kilogram. And with this single injection of this dual, so the split NTN AAV APE approach, we're able to prevent hypertrophy quite well. So again, in black, we have the wild type, so maybe no mutation, no hypertrophic cardiomyopathy. In blue, we have the treated one. So as you can see, the left ventricular posterior wall thickness is not increasing, and it's similar to the wild type. So hypertrophic cardiomyopathy in this regard, the phenotype was not present. Whereas in blue, in red, you can see the untreated R403Q mice. So the hypertrophy is present, and the difference between treated and untreated are significant in this regard. And compared to the nuclease approach, again, the dosage was more or less like similar between both. We don't see any decline of the left ventricular function, so the fraction shortening is similar in all three groups. And also looking at histology. So on the left side, you have a wild type. You see like a beautifully configured left ventricle of a mouse heart. You see the R403Q treated mice. So the one that we treated with the single injection of dual AAV. The thickness is more or less comparable to the wild type, whereas on the right side, you see like this heavy fibrotic hypertrophied heart. And also, if you quantify the fibrosis area, you see a significant difference between these two mice and hearts. The question is, of course, as I said, so bystanders mutations are an issue, and you have to really have to look for it during sequencing. And you can see the A10 and A11 position. So these two A up here, in the left ventricle, there's editing happening. But more or less, if you looked at the phenotype of the hearts, also like the fibrosis content, the function of the heart, it didn't change anything in this regard. And we had a little bit less in the RV and even more or less in the left and right atrium, but that's expected because we also had less on-target editing efficiency, right? Then also RNA editing could happen with using these adenine base editors, but we didn't see anything in this regard. And then I would like to quickly introduce the last version, or the newer kid on the block, the prime editors, which are actually like nowadays actually the one you probably want to use later on. Of course, right now the in vitro efficiency is getting better. I mean, there's a lot of dynamics in this whole field of CRISPR research. It's getting better. In vivo editing it's not as if the efficiency is not as comparable to the nuclease approach or the base editors, but it's also getting better. In this regard, you again has a mutated Cas9, which is actually then called a nickase again. So we only produce a single strand break as shown here, and attached you have a reverse transcriptase, and also this PEG RNA which actually has a template, actually basically a template how you want to change your DNA. And that's the beauty about the prime editing. So you basically are not restricted to like cutting and producing indels like in the nuclease approach, and you're not restricted to the approach of base editing where you change single nucleotide, right? So you can actually like change your DNA as you want. And with the single strand break, with the usage of reverse transcriptase, and then the final repair mechanism, you're able to basically produce any genome editing that you want. But as I said, the efficiency is not comparable to the nuclease or base editing approach. So there are still a couple of questions that need to be addressed on the way to clinical application. The question is, when should we treat? Should we do like an early or late treatment in patients actually who are actually phenotype negative, which have maybe family members with a severe phenotype, but who are a carrier of this variant, but actually are still phenotype negative? Do we want to treat them or not? I mean, the penetrance might be different in that particular patient, right? Then reversibility of present phenotypes. When I treated, so these mice that are presented today were treated quite early in life, right? So when the phenotype is present, fibrosis is around, it's not that easy to approach the cardiomyocyte that much so far. And are there actually more sensitive biomarkers present next to NT-proBNP, for example, or like repetitive transthoracic echoes or MRIs that will tell us, okay, it's time for treatment, right? This is maybe circulating DNA, circulating RNA, cell-free RNA, we don't know, or even like single cell signatures. And are we actually able to prevent or to modify this disease by a single shot, or do we need multiple shots? That's an issue regarding AVs, for example, where we can actually develop antibodies against, right? And then we would have a severe immune reaction if we want to treat again. And then we probably need to tackle also transient expression of gene editors. We need to think about kill switches like off switches or self-limiting AAVs to really like prevent ongoing expression. What we do right now in Munich is actually that we really want to go into like the translation model. We have pig models around which actually have a hypertrophic cardiomyopathy or CPVT. And we're going to use like different approaches, different delivery methods, and also want to address safety issues with this. Quick summary, we're able to successfully in vivo genome edit mice. So it's preclinical to prevent genetic hypertrophic cardiomyopathy. We used two different approaches, Cas9 nucleases and base editors with high efficiency. Prime editing is certainly long-term the way to go, but still needs improvement. And as I addressed already, there are a couple of next steps that are identified and need to be addressed. And with that, I would certainly say thank you to the audience, and especially also thank my mentors, John and Cricket Seidman in Boston, who helped me a lot, and also as well Greg Newby, who's now at Johns Hopkins University. Thanks a lot.
That was excellent, Daniel. Thank you very much, and really appreciate you coming on all the way from Tokyo, which must be very late for you there right now. So anyway, this is a terribly interesting, exciting field. There's, you know, I work in amyloidosis, and so I'm aware there are some clinical trials at early stages that are now testing this in the clinical setting. So you touched on what was going to be one of my questions. So it looks like in HCM, most of the work thus far has been in preventing hypertrophy and the phenotype, but thus far there hasn't been success with reversing. Do you think that's something that you know eventually we'd be able to overcome? Because unfortunately, you know, many of these patients only come to our attention once they have the disease established. So we don't know we don't always know the genotype of people ahead of time before they get the disease. So do you think that, that the obstacles are, preventing use to reverse the disease? Is that something that you see in the future?
Yeah, excellent question. So that's actually what we tackled right in the beginning as well. So we used 20-week-old mice, which actually have a present phenotype, heavy fibrosis, as you saw in the histology pictures, right? And there, with this approach that we used in the very young mice, we're able to edit around about 2 to 3% of cardiomyocytes, which is like, if you compare what we achieved at early stage, which is actually like terrible, right? So using the same approach, right? So lately, I spoke with Cricket Seidman about it, and she said that with like different vectors, actually, for example, the MyAV, which has been developed also at the Broad Institute, which is very like more cardiotropic. Actually, they achieved better editing efficiency. So it's certainly possible. I think at the end, if we look what tools we have in hand right now, like nuclease, base editors, prime editors, right? With prime editors, a little bit with asterisks, right, regarding editing efficiency overall. I think the delivery is the main issue, right? So is it going to be the AV? Is it going to be AV9, or is it maybe even like AV6 or something else, a different serotype, or is it a zero subtype? Or is it maybe like a lipid particle, as we use, for example, in all the COVID-19 vaccinations, right? So I think that's the main point, and this is actually where a lot of thoughts went into already lately, and will go in. And I think this is why I think it's so important to also go into large animal studies, because I think this will give us more insights of how to modulate that the best. Yeah, but I think it will be possible, but I think delivery and what kind of delivery will be key.
Just a reminder to the audience that if you have any questions, just to pop it in the Q&A section.
Daniel, are you involved with any, so right now you've presented work in preclinical setting. Are you involved with any translational studies or aware of any work happening in humans?
Regarding amyloidosis, probably that's one question. Yeah, we will be involved in that trial, recruiting patients. So let's see. I'm very curious how that's going to be. Otherwise,
sorry, you said you're involved with the amyloidosis trial. Is that what you said?
Yeah. That's going to be like, also we're going to recruit patients. But regarding hypertrophic cardiomyopathy, no, there's nothing in this regard going on right now. But hopefully we can address with the large animal studies a lot of questions and then move on. Yeah. On the other hand, I mean, we have a beautiful new medication with mavacamten, right? So you also have to be aware that we have like good other options right now. But my opinion is actually, when we get, like, for example, in hypertrophic cardiomyopathy, great results in large animal studies, we can actually not only treat like hypertrophic cardiomyopathy, right? So there will be many options if we're really able to directly target certain cell types in the heart and with high efficiency. So that's not only then restricted to hypertrophic cardiomyopathy. It's just an example that I showed today.
You mentioned mavacamten. We know that can sometimes affect LV function, and you also showed some data that some of the CRISPR technologies can also affect cardiac function. So have you studied the two combined, like if there's any effects, adverse effects in small animals receiving mavacamten in the background? Is that a concern, or?
Well, I wouldn't, in that directly, like with the injection, I probably wouldn't apply mavacamten as well, because I mean, we see in certain patients like a decline of the ejection fraction, so I would be worried about that. But down the road, of course, I mean, it also depends on like how the results are going to be with the non-obstructive hypertrophic cardiomyopathy trials. Let's see when we have more insights into that. But yeah, combining right now, I wouldn't do that probably.